But you have some questions.
Yes, I have several questions from our participants. First, I'd like to thank our participants because we are having lots of participants from different parts of the globe, from Egypt, from Pakistan, from Saudi Arabia, from El Salvador, from Romania, from Budapest. So thanks for joining us for this valuable talk by the eminent Professor Gabor Racz. So let's take some questions for 10 minutes. Well, the first question is that this is an excellent talk, sir. I would like to know your opinion regarding treating lumbar canal stenosis.
Lumbar stenosis.
Yes.
Very good results. The question is, in the cervical epidural space, there is a paper from Korea, a publication, where they compared severe cervical spinal cord stenosis to moderately severe spinal stenosis as established by radiological criteria. And they found at the end of this large study, no difference. Both groups did very well. So this issue has been studied. Transforaminal injections are hazardous if you use a sharp needle, because if you inject into a nerve, you get infarction of the spinal cord, because injection into the nerve spreads into the less resistant spinal cord, where it destroys this blood supply to that segment. So you get infarction of the cord. You know, the procedure, if you have pain because you have compressed the blood supply to the cord, is flexion rotation to distribute the fluid, because the dura moves. And one way of finding out when you have this scarring triangle related adhesion is I'm deviating a little bit from your question. Does it work? Yes, it does. I do a transforaminal catheter to ventral epidural space, and I always look at the MRI, because any injection is hazardous, particularly when there is no spinal fluid, because you cannot inject the smallest volume in the epidural space without putting some pressure. And when you have at least half of the epidural space is without any spinal fluid, you might be able to open up, but I would not at the beginning do anything that is a bigger volume injection. So you look for, I'm telling you about my criteria for myself. I like to see fluid all the way around the spinal cord. And when you open up lateral runoff, then you can go back in the ventral epidural space transforaminally and open up venous runoff, because a lot of the obstruction in the epidural space is distended veins. And when you open up below the level of the occlusion, not above, below the level of the stenosis, and come to ventrolateral and open up some venous runoff, you open up spinal fluid to get to the area where you are. I visited South Korea, and that's why they do so many neuroplasty papers. Visited all the academic centers, and I did 157, I believe, cases in 3 visits, where I worked 4 days driving from one hospital to the other, doing about 50 cases a week. And I said no to 1 neuroplastic case. And I would recommend to you that start, because you watched us do the Spanish guy, but we did not notice at that time that you don't want to point the catheter up. When you come from the left side, you just rotate it 90 degrees so that catheter goes straight up, because it's more medial, the space, than lateral. So you have to be in the posterior, actually in a ventral epidural space between the dura and the posterior longitudinal ligament. And the tiny catheter goes there. The little bit bigger catheter cannot go into the scar. The scar is like a honeycomb. That's the honeybee goes in through the hole. There's a big nasty bumblebee, the big fly that wants to eat the honey, don't want to go into the hole, but he can't get it. You cannot get into the honeycomb to eat the honey. But that's the similarity, that a bigger catheter cannot go in, but it's a newly made, new design, tiny catheter, and you can get this one from Cairo Medical and contact the EPIMED guy, and you can solve the problems. But regular catheters don't go into it, and it's not safe.
Okay, we have another question from the Facebook. It's from a doctor from Turkey. He is telling, thank you for this amazing talk. Please, we want more of these talks on Facebook and live. So my question is, can I reach the scarring triangle through the sacral hiatus?
You cannot. You cannot get to the really serious. You see, if you read the paper by Teskay, it's important to read it. Read the discussion. And they describe that when the German spine surgeons put the needle into the scarring triangle, then a small volume injection goes a long way. And the German spine surgeons thought that this is good for epidural injections. Because God put that scarring triangle for the German spine surgeons to inject all over the place. No. God put that scarring triangle to drain the loose fragments into an area where scar formation doesn't come for a long time. But when scar formation comes, it prevents you from going into the ventral epidural space, period. You can get into the posterior epidural space. And when we wrote the second book, and I repeated the caudal approach to that patient, he was not very happy with me, because he didn't get 22 years pain relief. He got a few months, like epidural steroids, because I got into the epidural space with the regular catheter. And when I got in, I ended up over in a lateral epidural space, but I was not be able to, the tip of the catheter curved down and not be able to inject the ventral epidural space. You have to be in the ventral epidural space. And he was a very happy patient for 22 years and was not so happy. And we published the case 22 years later, and it took me several other years to realize why was he unhappy with me. Because you are not in the ventral epidural space to open up the mobility of the dura. It is the dural mobility disappearing, and every time you move, you pull on it. And the test is when you sit up and elevate the legs and bend forwards with the head bent down, all the way down, and then you move the head down. And when you move the head, the dura is attached to the foramen magnum, and it pulls on the dura more lower down, because we have 3 electrodes in that patient. The upper 2 on the side, they don't move as much as the lower electrode. You could see the 4 electrodes moving up and down and sideways. So let me finish this, or whatever questions you have. The dural tug is when you sit up and bend forward, bend it head down, and then the patient will have pain going down into the hip.
So actually, I've answered the coming question from Romania. What is the difference between dural tug and dural flossing? I believe that Dr. Racz had just answered this question.
One of my colleagues, I was very impressed in the early 80s when
What's the difference?
the first picture was put in by Blumberg to look with a rigid scope and an angled lens. And beautiful pictures. I was very impressed. And I told my colleague, Dr. Jim Hebner, and he developed this as, you don't use a rigid scope. You need to make it flexible. So Storrs gave him a computerized column, very expensive, and he could write papers. He developed the flexible epiduroscopy. Epiduroscopy is not any better. There's studies comparing epidural and neuroplasty.
Difference between dural flossing and dural stretch.
Yes, yes, I'm being reminded I failed before. Please turn your mind off for a second. I told you about dural tug. And when you finish the case and the patient goes home and he does a dural tug, and he may find some pain on the other side. And I had this patient who is Stuart Fitz. So it's the Racz Fitz exercise, the dural flossing, when you move on it. And he went home and he couldn't play golf. And after I did, he had a no radiculopathy. So it's not a nerve entrapment. The straight leg raising is negative in most of these patients because physical therapists don't know about dural flossing or dural tug. They don't do it. but the dural flossing or Racz fits, F-I-T-T-S, is when you bend forward and then you keep pulling and you look for the pain, and you, because the dura moves and provokes the pain, when you find the spot, and when you are on the spot, you keep doing the dural flossing. And one of my patients that I did 3 weeks ago, and I was away for 2 weeks. I just got back from Aruba. It was beautiful, sunshine, sand, walk in the ocean, beautiful. Anyway, he called me to tell me that every day he's doing the Racz fits or dural flossing, that his pain is going away and he's doing great, and every day is a better day than the day before. It's 3 weeks. And the first guy, he had pain. We don't know where we are, but putting in 10 cc's of contrast, 10 cc of hyaluronidase, 10 cc of, I'm sorry, 1.5 cc of 1% lidocaine, wait 2 or 3 minutes. But these are printed, and you can attach to this, if you get the printed form for the final edition, just so people can know the times and the concentrations, so to reduce the waiting time between doing different, the different procedures. So it's worked out for the most cost-effective, best studied, best procedure that there's only one other procedure has had a double-blind long-term follow-up, like 2-3 years. That's high-frequency spinal cord stimulation, because you can turn off the unit and the patient not know it, because you don't know when the unit is on, and high-frequency stimulation does not cause paresthesia. So neuroplasty and high-frequency stimulation, the only 2 studied pain procedures that have placebo-controlled trials. So it's a best studied, 100-some patients, papers, published in respectable journals. So it's a good procedure for you to learn, and if you invest your time, it's time-consuming, and it is simply the best. And I don't waste my time doing anything else very much. I've done, yeah.
So the